Good afternoon, students. Today I am going to discuss with you one of the important public health problem, both nationally and internationally, the dengue syndrome. Syndrome is a Greek word where syn means together, drone means run. So syndrome is a group of symptoms or collection of findings seen in a number of individuals and associated with a specific disease. Where disease is a definite health condition having clearly definite reasons and with definite anatomical physiological changes and most probably definite treatment. So our discussion, the dengue syndrome, it is an acute viral infection of tropical and subtropical regions around the world, mainly found in urban and peri-urban area, but now it has also been enclosed to rural area. Over the past 3 decades, a number of epidemic outbreaks has occurred globally with all types of dengue presentation, dengue fever, dengue hemorrhagic fever, dengue shock syndromes, and thereby causing one of the major international public health problems. This is the infection caused by arboviruses, flavivirus. There are 4 serotypes. We will come to it later on, and it's spread by Aedes mosquito. Disease spectrum has wide range. It starts from asymptomatic to non-specific febrile illness to fatal hemorrhagic disease with or without shock. Dengue, the problem statement. It is endemic in more than 100 countries of WHO regions, but the most affected part are the Southeast Asian region and Western Pacific. And depending on the affection, the Southeast Asian countries are divided into 3 categories. Category 1, Bangladesh, India, Indonesia, Maldives, Sri Lanka belongs to this category 1. Characteristic feature of this category A district are there is hyperendemicity. That means incidence and prevalence are both high and it affects all ages. But the category B country, Bhutan, Nepal, where some of the outbreaks have occurred, but now the endemicity not known. Category C districts, Korea, where endemicity unknown. In India, dengue is endemic in all the states and union territories except Lakshadweep. In northern India, rising of cases occurs from July to November, where southern and western parts of India, disease occurs throughout the year. And July is the month for dengue. Now coming to the epidemiological determinants. Agent is flavivirus, type of RNA virus, arbovirus, that means arthropod-borne virus. There are 4 serotypes. Dengue virus 1, dengue 2, dengue 3, and dengue 4. Infection with one serotype confers lifelong immunity to that virus only, but it has no cross immunity to other types. Probably the first infection, that means infection with dengue virus 1 type, sensitizes the patient while it occurs repeatedly or in the same time with different serotypes. It produces immunological catastrophe which gives rise to severe form of dengue. So, severe form dengue, that means dengue hemorrhagic fever or dengue shock syndrome. Either it occurs repeated infection or in the same time by different serotype of dengue virus. If it occurs, then it causes immunological catastrophe because the primary infection sensitizes the immune system, and in where secondary infection it causes hypersensitivity leading to severe form of dengue, that is dengue hemorrhagic fever and dengue shock syndrome. and which type of strain is circulating in the environment, it may influence the magnitude and severity of viremia in man. All the four serotypes have been associated with epidemics of dengue fever with varying degrees of severity. Some Thailand study has shown if an individual first affected with dengue 1 and then recurrent infection with dengue 2, there is chance of immunological catastrophe 500 times more. But if affected with dengue 3 and then followed by secondary infection with dengue 2, then this risk of immunological catastrophe or hypersensitivity is 150 times. Now the vector of dengue, all of you know that Aedes mosquito is the vector. Main type is Aedes aegypti and Aedes albopicus. They are called also tiger mosquito because white stripes are seen on the black body. Their tendency is endophilic. That means they prefer to stay inside houses in the dark, hard area. They are the domestic breeder. So in peri-domestic region, they breed in any artificial accumulation of water found around human dwellings. They breed, which may be any broken pot, broken bucket, any flower vase, any artificial accumulation, overhead tanks, tires. On the other hand, albopicus prefer to breed in tree holes or any plantation. Aedes aegypti mosquito can live without water for more than 1 year, and when they come in contact with water, they can emerge within 24 hours. They bite during daytime, but their flight range is short, usually less than 100 meters. They are strongly anthrophilic and bites more than one host to complete their one blood meal. This is the reason clustering of cases of dengue occurs due to this specific characteristic feature of the female Aedes mosquito. They bite more than one host to complete one blood meal. Dengue infected person becomes infected 6 to 12 hours before the onset of fever to day 5 of illness. That is the viremic phase of the disease. After blood meal, the infected mosquito, there is extrinsic incubation period for 8 to 10 days where the virus multiplies within the body of the mosquito and it is propagative type. Now the environment, all of you know that mosquito population fluctuates with rainfall and storage of water. The time and the relative humidity 60 to 80% and the temperature of 16 to 30 degrees centigrade is the optimum for best survival of the mosquito population. Inadequate public health activities which are conducive to increase in mosquito population in urban areas. In urban areas, more and more number of cases of dengue cases are found due to the unplanned developmental activity, lifestyle of the population of urban areas, along with insufficient public health activities, poor drainage system. All these are responsible for increased cases of dengue in urban areas. Now the rural areas are also been associated with dengue due to rural water supply scheme, improved transports and lifestyle changes. So some factors that influences occurrence of epidemic are circulating viral strain or number of strain which are circulating in the environment, density of the vector population, density of the human population, age of the patient, immune status of the host which depends both genetic and pre-existing immune status that decides an individual is susceptible to dengue infection. whether it is a primary or secondary infection, which determines whether dengue will occur in minimal form or in severe form, unplanned developmental activities, deficient water management. So all these environmental factors has great influence on the occurrence of epidemic in a community. Now coming to the host factors. It can occur, it affects all ages and both sexes. And regarding susceptibility of the individual, both genetic and pre-existing immunological profile is responsible. Both man and mosquito are the reservoir of infection. But during outbreak, rate of hospitalization and rate of death are more among children during dengue hemorrhagic fever outbreak, which is now occurring in UP. High risk groups where the severity and complications of dengue fever is more, those groups are infants and elderly population, obese population, pregnant mother, peptic ulcer disease, or any individual having other comorbidities. They are more prone to suffer from severe form of dengue fever. They are congenital heart disease, ischemic heart disease, other chronic disease like diabetes, hypertension, asthma, chronic renal failure, liver disease, hemolytic disease, G6PD deficiency, thalassemia, under steroid therapy or non-steroid anti-inflammatory drugs, under antiplatelet, anticoagulant, or HIV patient with immunocompromised states. All these categories having any comorbidities, they are more prone to suffer from severe form of dengue. Now coming to the pathophysiology of dengue. Most important feature in the pathophysiology of dengue, host immune response, which play the most important role in the occurrence, in which end of the disease spectrum the individual will lie. There are various mechanisms regarding pathophysiology of dengue are there, which are complex, and most significantly their clean-cut pathophysiological changes are not described. Two important things occurs, one is vasculopathy, another is coagulopathy. Reason for vasculopathy is multiple. First of all, endothelial injury by dengue virus or increased activity of the T cell mediated antibodies which cross-react with vascular endothelium, which in turn causes change in the fiber matrix of the endothelium. Anti-NS1 antibody also act as autoantibodies that cross-react with platelets, reducing them, and also non-infected endothelial cells. All these things causes disturbances in the capillary permeability, also which in turn results in plasma leakage, thereby hemoconcentration, pleural effusion, ascites. Another important thing which are also responsible for vasculopathy are activated complement and its product and various other soluble mediators like cytokines, chemokines. They result in cytokine storm, which finally target either vascular endothelium or platelets or various organs, which represents different manifestation of dengue. Second thing which occurs in dengue is coagulopathy, which is well observed, but exact mechanism still remain unclear. Two things persistently found as a result of coagulopathy in dengue is partial thromboplastin time activated and reduction in fibrinogen concentration, which are the consistent findings. Thrombocytopenia with coagulopathy increases severity of hemorrhage. So vasculopathy and coagulopathy leads to hemorrhage and shock, hypotension, pleural effusion, ascites, bleeding, and involvement of the different organs. So major causes of bleeding in dengue fever or dengue hemorrhagic fever are thrombocytopenia either due to destruction of platelet by antiplatelet antibody, platelet dysfunction, peripheral sequestration of platelets, or abnormal coagulogram. Or it may be due to secondary to liver involvement resulting in deficiency of prothrombin complex, disseminated intravascular coagulation also occur as a result of cytokines, different vasoactive mediators, procoagulants, and increased activated partial thromboplastin time, which are the consistent findings in dengue coagulopathy. Decreased fibrinogen level and increased fibrin degradation products are also responsible for bleeding. Now coming to the clinical manifestation of dengue virus infection. I have already told that a spectrum of disease occurs in after following dengue virus infection. They may be asymptomatic. This part of the asymptomatic dengue virus infection represent the portion of the iceberg below waterline, and tip of the iceberg represent the symptomatic part. In symptomatic part, undifferentiated fever may occur, or classical dengue fever syndrome. It may be associated with without hemorrhage or with unusual hemorrhage. Then comes the dengue hemorrhagic fever with or without shock. Another category also occurs in those persons having comorbidity or other co-infection, that is expanded dengue syndrome, isolated organopathy, or any other unusual manifestation. So, dengue, symptomatic part of the dengue infection may cause undifferentiated fever. Temperature rises 39 to 40 degrees centigrade. It usually occurs primary infection with dengue virus. It may be associated with maculopapular rash or any GI infection and upper respiratory tract infection. Now the second category is classical dengue fever. Incubation period of dengue fever is usually 3 to 10 days, on an average 5 to 6 days. Sudden onset, high fever, 39 to 40 to 41 degree centigrade. It may be biphasic, some cases. That means the fever rises, lasts for few hours to one day, and then can come down, and the second peak occurs. It may be associated with headache, muscle and joint pain, retroorbital pain, anorexia, vomiting, constipation, pain abdomen, weakness. And rashes may appear in 80% of the classical dengue fever. These rashes are maybe diffuse flushing or mottling or fleeting pinpointed. It may convert to maculopapular rash. And the first phase, it may appear in face, neck or chest. And when it may be maculopapular, that means day 3rd or day 4th day of the fever. There it appears chest and trunk, and then spread to extremities and rarely to face. So it may be diffuse flushing, mottling or fleeting pinpoint in the first part of the fever, and where it is found in face, neck and chest, and it may convert to maculopapular where it is day 3rd or day 4th. In such cases, it is found chest and trunk, then it spread to the extremities and rarely to the face. Now the severe form of one of the severe form of dengue fever is dengue hemorrhagic fever, and this dengue hemorrhagic fever are divided into 3 phases: febrile phase, critical phase, and the convalescence phase, by reabsorption phase. Febrile phase, like classical dengue fever, it occurs 39 to 40 degrees centigrade. Symptom of fever may be associated with rash, but sometimes it may not be present. Fever usually lasts for 5 to 7 days in case of classical dengue fever, and if it is not accompanied by any other catastrophe, that means plasma leakage or abnormal hemostasis, then recovery occurs completely, but convalescence period may be prolonged. In these classical dengue fever cases, if not associated with any complication, then case fatality rate is low, comparatively low. Now the dengue hemorrhagic fever, febrile phase is similar to that of classical dengue fever, and febrile convulsions may occur in infants, and the severity of these dengue hemorrhagic fever depends on two major things. One is if the plasma leakage occurs and associated abnormal hemostasis. Critical phase starts day 3rd onward, day 3rd to day 7 of the illness, when the fever subsides. That means in afebrile phase, critical phase starts. It is associated with increased capillary permeability and abnormal hemostasis. It marks the beginning of this phase, and this critical phase also lasts for 24 to 48 hours. If the patient can be properly managed during the critical phase, these 24 to 48 hours, then patient may survive. And it is manifested with the help of positive tourniquet test. It is the most common hemorrhagic phenomenon diagnostic. It is done by inflating a blood pressure cuff to the midpoint between systolic and diastolic pressure and kept there for 5 minutes. When associated with small petechial hemorrhages in 1 inch square side, if more than 10, it is said to be positive. And in case of dengue hemorrhagic fever critical phase, it is usually 20 or more. This critical phase of dengue hemorrhagic fever is also associated with progressive leukopenia followed by rapid fall in platelet count, which usually precedes plasma leakage. And further clinical feature depends on the degree of plasma leakage, and it is often preceded by warning signs. So, this critical phase of dengue hemorrhagic fever often preceded by warning signs, which are recurrent vomiting, pleural effusion, ascites, edema of the gallbladder, abdominal pain. Also, spontaneous bleeding from different sites like epistaxis, melena, hematemesis, bleeding from gum, or it may be associated with palpitation depending if the pleural effusion is high. Ascites, breathlessness may also occur. If associated with shock, then cold clammy extremities can be found. There is also hepatic dysfunction. During this phase, decreased urine output and hematocrit may rise. All these are more than 45%. It usually occurs, this high hematocrit greater than 45%. And there is also rapid fall in platelets. Rapid pulse. There is hypotension and narrow pulse pressure. So further clinical feature will depend upon the amount of plasma leakage, which may progress to shock, and with prolonged, if the shock continues, it may lead to impairment of other organs like severe hepatitis, encephalitis, myocarditis, metabolic acidosis, or disseminated intravascular coagulation, which occurs in expanded dengue syndrome. And coming to the recovery phase of the dengue hemorrhagic fever. In this condition, there is gradual reabsorption of the extravascular fluid which have occurred due to plasma leakage, and this recovery phase is found in the next 48 to 72 hours. So, the critical phase lasts for 24 to 48 hours, and next 48 to 72 hours, if the patient can be survived in the critical phase, then next 48 to 72 hours is the recovery phase, where we can see the improvement of the vital signs. Urine output becomes better. And in this phase, some patient may also have another type of rash, that is islets of white in the sea of red, and this type of rash usually lasts for 1 to 3 days and may be associated with itching, and desquamation also occurs few days after. During the recovery phase, hematocrit stabilizes or it may be lower. During this phase, WBC count starts rising, but returning of the platelets to normal occurs later. So, one of the severe form of dengue is dengue hemorrhagic fever. Next come to the another form, severe dengue, which is called or dengue shock syndrome. It is defined by any one or more of the following. That means plasma leakage, which may lead to shock and or fluid accumulates with or without respiratory distress, and or severe bleeding, and or any severe organ impairment. All this belongs to dengue shock syndrome or expanded dengue syndrome. Expanded dengue syndrome, mild or severe organ involvement may be found in dengue fever or dengue hemorrhagic fever, and these usually expanded dengue syndrome are seen with comorbidities or co-infections. If it involves central nervous system, it may cause encephalitis, encephalopathy, febrile seizures, or intracranial bleeding. In case of GI system, it may cause hepatitis, hepatic failure, cholecystitis, cholangitis, pancreatitis. If it involves kidney, acute renal failure, acute tubular necrosis may occur. Cardiology, cardiomyopathy, myocarditis, arrhythmia, pericardial effusion. In case of respiratory, acute respiratory distress syndrome, pulmonary edema, hemorrhage or pleural effusion. If it involves eye, conjunctival hemorrhage may occur or macular hemorrhage and may be associated with optic neuritis or visual impairment. In case of dengue hemorrhagic fever and dengue shock syndrome, case fatality rate is 40 to 50%. Now coming to the laboratory diagnosis. Available laboratory tests are isolation of the virus. It is possible during the first 6 days of illness, serum, plasma or autopsy tissue from the liver, spleen, lymph node from fatal case, and also from the virus can also be isolated from the mosquitoes of the affected areas. That means where epidemic and outbreak are occurring, mosquitoes are collected and virus can be isolated from those mosquitoes. Another is nucleic acid detection of the virus. It may be done from RT-PCR, which have better specificity and sensitivity. It can be detected within 48 hours. Viral antigen detection, it may be more ELISA based or non-ELISA based. If it is detected rapidly, that means within minutes, their sensitivity specificity is not so high, but ELISA based is specificity high. Another thing is as a result of dengue infection, the immunological response and serological test, detection of IgM, IgG, seroconversion, and the rising titer in paired serum. One is taken within 7 days, and second one is 15 to 21 days, which shows 4-fold rise or 6-fold rise in the level. Different rapid diagnostic tests are also available, but their accuracy is uncertain. Most important thing other than this dengue virus diagnosis and antibody, hematological parameters are very important. It starts from the beginning, during management, during maintenance phase. Hematocrit value, complete blood count, platelet count, leukocyte count are important and part of the both diagnosis and management of dengue infection. So, analysis of hematological parameter, one of the mainstay of diagnosis and management of dengue. Now coming to the WHO classification and grading of severity of dengue infection. This grading of severity of dengue infection is very important because upon this grading, our management of dengue infection starts. First, the dengue fever, as we have already told, fever or with two or more of the following if present, then dengue fever is diagnosed along with laboratory findings, that is clinically headache, myalgia, arthralgia, retroorbital pain, rash, hemorrhagic manifestation, no evidence of plasma leakage is there, which is associated with leukopenia, less than 5000 WBC count per cubic millimeter, platelet count 1.5 lakh per cubic millimeter, and rising hematocrit, but it stays within 5 to 10%. This hematocrit rise stays 5 to 10% limit. Then comes to the dengue hemorrhagic fever 1, 2, 3 and 4. When all the above criteria of dengue fever is present, along with hemorrhagic manifestation is present, plus positive tourniquet test, evidence of plasma leakage is there, which is associated with platelet count less than 1 lakh and hematocrit rise is greater than equal to 20%. Dengue hemorrhagic fever category grade 2 is all the above symptoms and signs plus some evidence of spontaneous bleeding. Either it may be from gram, it may be epistaxis, or it may be melena, hematemesis, then which is also associated with platelet count less than 1 lakh per cubic millimeter and hematocrit rise greater than 20%. Dengue hemorrhagic fever grade 3, all the above signs and symptoms plus circulatory failure is there, but this circulatory failure is compensated. Still we can detect low blood pressure, pulse rate is high, but weak, feeble, with cold, clammy extremities, and it is also associated with platelet count less than 1 lakh per cubic millimeter and hematocrit rise greater than 20%. Along with blood pressure, this pulse pressure record is also important, which is less than 20 in dengue hemorrhagic fever 3 or 4. And in the stage grade 4, this pulse or BP becomes suddenly disappears. It becomes undetectable. That means it becomes decompensated. Here also platelet count remains less than 1 lakh per cubic millimeter and there is hematocrit rise greater than 20, it may be even 45%. Now the case definition of dengue for surveillance purpose, and it is a notifiable disease. All the cases of dengue fever is notifiable, both suspect, probable and confirmed. In case of probable dengue fever, any case of dengue compatible with 2 or more of the clinical description and laboratory findings of the dengue fever and outbreak is occurring and at least one of the following is found, that means non-ELISA based NS1 antigen or IgM positive and occurrence at the same time and locality confirmed cases of dengue fever is there, then it is probable dengue fever. For confirmed dengue fever, any case compatible with clinical description of dengue fever with at least one of the following, that means isolation of either dengue virus from virus culture, demonstration of IgM antibody titer by ELISA positive in single serum, demonstration of dengue virus antigen by NS1 ELISA, IgG seroconversion in paired sera after 2 weeks with 4-fold rise of IgG, or detection of viral nucleic acid by PCR, then it is called as confirmed dengue fever. Now coming to the clinical management of dengue. So WHO grading of the severity of dengue infection is very important, because depending on this we have to decide where to treat the patient, whether he or she can be kept at home or they need hospitalization. Severity of infection guides the treatment modalities, and another thing is very important, that is baseline value of full blood count with hematocrit value is very important, because we can compare with this baseline value. If the patient deteriorates, then only you can manage accordingly. When this baseline value is not available, then we can take the population based, age, gender specific, value which are present, and we can compare with that and manage accordingly. Management of dengue fever, most important thing is fluid therapy. In the early phase, that means classical dengue fever or undifferentiated fever, we can stay with the use of oral fluid, or it may be ORS, it may be fruit juice or any other fluid, or antipyretics, cold sponging for coming down bringing down the fever. Don't give aspirin, give only paracetamol or brufen or other non-steroid anti-inflammatory drugs, because they may precipitate GI bleeding. In case of aspirin, there is possibility of Reye's syndrome, that means involvement of the liver, which gives rise to jaundice. And another thing is most important, other than hematocrit value, vital signs, and also the urine output or any other warning signs, and caregiver is advised to bring to the hospital to the patient immediately. Always keep watch on warning signs, whether they appear in the patient, and then bring that patient to the hospital immediately. Management of dengue fever, hemorrhagic fever, febrile phase is same as dengue fever. If the patient is vomiting persistently, then IV fluid given, and they are closely monitored in the transitional period. When the patient becomes afebrile from febrile phase, then sought out for if there is any plasma leakage is occurring, and so which can be seen by serial hematocrit value around day 3rd of the illness, when the patient becomes afebrile from febrile phase. So repeated hematocrit estimation is must for management of dengue hemorrhagic fever. All these patients, grade 1 and 2, all these patients must be observed for shock and IV fluid with crystalloid, that means normal saline or ringal lactate given. If in spite of the treatment patient develop fall in blood pressure or urine output falls, then management of grade 3-4, that means dengue shock syndrome started. So mainstay of treatment is IV fluid, and monitoring is done with hematocrit, vital signs, that means pulse, blood pressure, platelet count also regularly monitored, and patient is managed with IV fluid, either crystalloid or colloid solution like dextran 40 or hemaxil. Whole blood is very essential for the management of severe form of dengue, and oxygen is also essential. So these things, close watch of the vital signs, serial estimation of platelet count, hematocrit, urine output, and along is essential. And mainstay of treatment is early initiation of IV fluid, close monitoring of the IV fluid, strict management of the patient with IV fluid, and also fresh blood, oxygen. All these are the most essential thing of dengue management, especially the severe form. So volume replacement algorithm for the patients with moderate degree dengue fever, that means dengue hemorrhagic fever grade 1 and 2. Or as we have already said, that these dengue hemorrhagic fever grade 1 and 2 characterized by bleeding tendencies and associated with thrombocytopenia less than 1 lakh and hematocrit rise either greater than 20%. So initiate IV therapy with 6 milliliter per kg per hour with crystalloid solution for 1 to 2 hours. Then repeat check hematocrit. If improvement occurs, gradually reduce this IV crystalloid solution from 6 milliliter per kg per hour to 3 milliliter per kg per hour to 1.5 milliliter per kg per hour for 2 to 4 hours. If further improvement occurs, discontinued IV 24 to 48 hours. But in the second repeat check of hematocrit, if there is no improvement, and two situation may arise. One is hematocrit rises, or another is hematocrit falls. If the hematocrit rises, then increase the IV fluid from 6 cc per kg per hour to 10 cc per kg per hour for another 2 hours. If the hematocrit falls, then we suspect internal hemorrhage may be there, so we start with blood transfusion, 10 cc per kg whole blood, or if there is already fluid overload is present, then we start with packed RBC, 5 cc per kg, but fresh blood transfusion is the always preferred. And if now the improvement have occurred, IV therapy by maintenance fluid, crystalloid successively reducing and then discontinue. What are the improvement signs? One is hematocrit level falls, start falling, pulse rate and blood pressure become stable, urine output rises, and when we will say that no improvement has occurred, when hematocrit or pulse rate rises, pulse pressure falls below 20 milliliter mercury, or urine output falls. Now coming to the volume replacement algorithm for patients with dengue hemorrhagic fever 3, grade 3. Grade 3 means compensated shock, which is manifested by systolic pressure is down, reducing, decreasing systolic blood pressure, pulse pressure is also low, high hematocrit rise. Then start intravenous therapy 10 to 20 cc per kg per hour with crystalloid solution for 1 hour. The same management. If the improvement in vital sign and hematocrit occurs, then gradually reduce the IV fluid and then finally discontinue. If no improvement, repeat check of hematocrit value. If it still rises from 20% to 45%, then first start increasing IV colloid or crystalloid. Colloid means that hemaxil or dextran 40 and wait for another 1 hour. If no improvement, then opt for thinking blood transfusion. Or another scenario where hematocrit falls and you suspect bleeding. Here also we start blood transfusion or Paxil if already fluid overload is present. And if there is improvement in vital sign, gradually discontinue intravenous therapy. Or if there is refractory hypotension, then see the sugar level, sodium, potassium, calcium, bleeding, whether any bleeding, suspect for bleeding or acidosis. If there is refractory hypotension and no improvement in vital sign, continue with IV therapy, oxygen, and finally maintenance dose with holiday cigar formula use. So here also the improvement means hematocrit falls, pulse rate, blood pressure stable, urine output rises, and no improvement means hematocrit or pulse rate rises, pulse pressure falls below 20 millimeter of mercury, or either urine output falls. Along with this, we see the vital signs, urine output, serial platelet count is also done, and all these cases of severe form of dengue should be observed, repeatedly observed every hour for vital sign, urine output, hematocrit, platelet count. Otherwise, we may miss the train. Now the volume replacement algorithm for patients with dengue hemorrhagic fever 4, that means here profound shock is present, pulse, BP undetectable, high hematocrit, we start with oxygen, immediate rapid volume replacement given in the form of bolus within 15 to 30 minutes, and check the vital sign and hematocrit. If it improves, then gradually reduce the fluid and finally discontinue. If there is no improvement in vital sign, then second bolus is given, check hematocrit. If there is improvement, then gradually reduce and withdraw. And if the again still continues to falls, then you suspect bleeding and give blood or Paxil volume as the situation arises, and also test for sodium, potassium, calcium, sugar level, bleeding, frank bleeding, acidosis, and manage accordingly. So the clinical management of dengue, indication of red cell transfusion, always whole blood is always preferred. If the loss of overhead blood loss is 10% or more, then we can say give Paxil or in those situations where refractory shock or fluid overload, we can also give Paxil. There is no role of prophylactic platelet transfusion. Even the platelet count goes below less than 20,000 per cubic millimeter, but it can be given if it comes down to below 10,000 per cubic millimeter. Prolonged shock with coagulopathy and abnormal coagulogram. There is systemic massive bleeding. In such cases, you can give platelet along with packed red cell. And what are the criteria for discharge from the hospital? If the patient becomes febrile at least 24 hours without antipyretic, or there is clinical improvement, there is return of appetite, urine output becomes good, 2 to 3 days have passed after shock, no respiratory distress, and platelet count greater than 50,000 per cubic millimeter, then we can discharge the patient from the hospital. Now we will tell about the prevention and control measures for dengue. As I have already said, the dengue is a notifiable disease. So all the cases of suspected, probable and confirmed dengue should be notified to the appropriate authority. Under National Vector-Borne Disease Control Program, main area of control of dengue is early case reporting and management. For this reason, there is system of fever alert surveillance is there, sentinel surveillance with lab support is there, and strengthening of referral service is must, because which case of the dengue infection will convert to severe form, we don't know. So always there must be good robust referral system must be there, and provision of transport should be there. Involvement of the private sector is also necessary. Case management, as all of you know, that case management definitely essential. Proper case management along with gradation and IV fluid and all other supportive measures. Epidemic preparedness and rapid response is essential for dengue outbreak control. Another major area is vector control, which is done integrated way by anti-larval, that means source reduction, use of chemical larvicide, use of larvivorous fish, Gambusia affinis, or anti-adult measure like indospray with 2% pyrethrum extract is given to the house where the case has been found. Even in epidemic outbreak, fogging with malathion is given to the whole ward or a whole village. Other than this, personal protective measure is always there, protective clothing, insecticide treated bed nets. Other supportive interventions are the development of the human resource. 15 apex institutions have been identified where there is strong lab system support is there, quality control, proper management of dengue is there, and every district there is sentinel surveillance with lab support has been kept. Another important thing is behavior change communication, because weekly dry days must during rainy and post-rainy season, where all the artificial accumulations of water are become dried, and weekly dry day is maintained. Supervision monitoring is also essential. Intersectoral convergence, that means health and other department, that means drainage system and the water supply system, and this intersectoral cooperation is very essential and acts as supportive intervention for integrated vector management. Now coming to the dengue vaccine, there are a number of dengue vaccine which are candidate vaccines in the different stages of development, but the most important one is live attenuated tetravalent chimeric vaccine, that is hybrid microorganisms which are created by nucleic acid fragments of 2 or more microorganisms replacing membrane and envelope antigen from attenuated 17D yellow fever by, and this replacement is done by 4 serotypes of dengue virus. There are 3 dose schedule. 0.5 cc subcutaneous is given 0 6 12 months for either 9 to 45 years or 9 to 60 years depending on the marketing. Which one is available in the market is named as dengue vaccine. It is given in people residing in endemic area. Global strategy for dengue prevention and control are reduce dengue mortality by 50% and morbidity by 25% by 2020. Any area is declared to be free from dengue epidemic where Aedes aegypti index is 0. That means house to house surveys, Egypt Aedes index is 0. House to house survey is done where denominator is the number of households surveyed and numerator is the those houses which have where dengue mosquito larva has been found. That means it is aegypti. If it is 0, then that area is declared to be free from epidemic, or twice the incubation period from last case of dengue has lapsed following last case of dengue fever. These 2 criteria are maintained, then that area is declared to be free from dengue epidemic. Thank you.